Hi, this is Mutlu Vural. I'm sharing you a case with acute anterolateral myocardial infarction. There is total occlusion in the ostial LAD. There is no critical lesion in the RCA. RCA is dominant. After predilatation, reperfusion is achieved, but we realize that there is a big diagonal here, and the ostium angle in the ostium is very wide. It will be difficult to wire this diagonal. After 15 minutes of wiring attempt to the big diagonal, we decided to put a stent to the LAD because LAD is the biggest vessel in the coronary system, and we should guarantee the survival of the patient because he is prone to preshock. LAD is a big artery and it is occluded from the ostium, and now LAD is revascularized, but diagonal perfusion is not good, and wiring should be more difficult at this point. We tried many wires, pilot 150, pilot 200, workers wire, many others. This wire is Hornet 14. Actually, it's a CTO wire, but we succeeded to penetrate the ostium of the diagonal with Hornet 14, but unfortunately we couldn't deliver microcatheter for wire exchange, so we have to work over the Hornet 14 in this case. After alternate dilatations of each vessel, we made kissing. This is the final result after kissing, and diagonal was a big artery. Because there is a short lesion in the ostium of the diagonal, we didn't plan to put a stent for the diagonal. The patient discharged 4 days later. He had only ischemic hepatitis. His transaminases level were increased up to 2000s, and he recovered completely after 4 days. And we put stent for the circumflex artery at another session, and patient condition was good. His ejection fraction was 45. Thank you very much. This is the lesion in the circumflex artery, which is treated at another session. What is the key point in this procedure? Wiring attempt. After failing wiring attempts of bed angulated side branch, we can first thing guarantee the survival of the patient. Just put a stent for the culprit lesion and then try to rewire the side branch, and we can use CTO wires with microcatheters for the last resort, and in this case it was successful. Probably we made subintimal penetration in the ostial part, and then we were in the lumen after a short subintimal tracking.